Hello, good morning to some of you and good afternoon to others of you. It's great to have this session continuing. What an amazing session we just had with Brendan Murphy and Kerry Chant. Well, we have yet more fantastic things to come. Here we're going to be looking at the impacts of a pandemic, making the best of it. My name is Louise Bauer. I'm chairing the session. I'm Chair of Child and Adolescent Health at the University of Sydney, and until yesterday I was a member of the Academy's Council, and I've been involved in the organising committee for this. The discussion today considers the broader impacts of the pandemic and some of the unexpected opportunities, including ways in which we could capitalise on the disruption to the health system, as well as lessons for the future about public perspectives and behaviour and how we might incorporate these into efforts to address future health challenges. I'll introduce each of our 5 speakers briefly, and in turn each one will speak for about 4 minutes. And at the end, we hope to have a reasonable amount of time for panel discussion. Please use the Slido to ask questions as you've done before, and you can upvote them as before. I want to now come to our first speaker, Alan Cheng. Alan is an infectious diseases physician, Director of Infection Prevention and Healthcare Epidemiology at Alfred Health, and Professor of Infectious Diseases at Monash, and he was mentioned in dispatches by Brendan Murphy just a little while ago. Since January, he's been involved in the response to COVID-19 as an invited expert to the Australian Health Protection Principal Committee and the Communicable Diseases Network of Australia, and since July as Deputy Chief Health Officer in Victoria. Alan will discuss needs and opportunities looking ahead. Thank you, Alan.
Thanks very much, and thanks for the opportunity to speak to everyone. Just noting, I am acting Victorian Deputy Chief Health Officer. I've also been involved in a number of other committees. I'm co-chair of ATAGI, the Australian Technical Advisory Group on Immunisation, and the Advisory Committee for Vaccines. And before all of this, I was a hospital clinician, but involved in research. So one of those trials has been the REMAP CAP trial, which is a clinical trial that is pivoted to COVID. And then the FluCan system, which is a surveillance system for influenza, obviously very easily pivoted to collect data on COVID. So some of the needs and opportunities that I see really are about the interface between academia and clinical medicine in my previous job and public health in my current acting job. And part of that is about getting real-time access to data. I can see from the public health point of view that people are so in the moment and trying to respond to to the actual situation that things like trying to work out who's got ethics approval and getting access to data isn't always at the top of the list, but it is important. And part of that is having a governance structure for that, so and preferably set up ahead of time. I think things like data linkage and making the most of the data that we have, particularly at the national level, not just at a state level, is particularly important. I think clinical trials and observational registries are, have shown their value. And, if you look at the most successful of these, probably solidarity and recovery trials, even though a lot of these were started at the last moment, a lot of the planning and thinking had probably gone into it before our time. I think there's still a big need for primary care research and involving primary care in the public health response and looking at models of care, particularly models of care that are pandemic ready. I think there's certainly a number of models around the world, particularly Singapore, which have had a good model before this. The role of occupational health physicians. And then I guess research into communications and engagement, the way that government communicates with the public is often very different by necessity than commercial entities. For example, the government needs to communicate to everyone, whereas professional advertising is often about trying to find the one group that will buy your product. And then finally, I guess drawing on my experience is really academia and clinical medicine as a surge workforce for public health. So obviously there's a lot of skills we can bring, but clearly there's also a lot of things that we don't know about government and how government works, and having a workforce that is cross-trained and has the skills and the familiarity with how government works is particularly useful. So I guess some of the questions that I had thought about that might be worth discussing would be how best to bridge this gap between academia and government. Can we establish data observatories for trusted providers to analyse data and have access to data? How do we best scale up research from small studies and trials to large national studies? How can we establish mechanisms that can quickly pivot to become trials? And so an example would be observational registries that have trials embedded within them. What is the best balance between rigour and speed? So as an academic, I'm always trying to be slow and cautious and rigorous, but you know, evidence needs to be synthesized in real time, and decisions need to be made very quickly. And then finally, I think what we see in particularly the scientific processes, we're seeing, you know, the scientific process play out in a highly politicized environment in real time. And, you know, these are the sort of the things that we see are the sort of debates that we would see now played at conferences behind closed doors, and now in the era of social media, it's much more visible, and how do we build trust in science and the scientific process? So I'll stop there. And
thank you so much, Alan. Those were really useful questions. I want to answer every single one of them, but we need to go on and listen to some more amazing people talk about their thoughts as well. We now move to Professor James McCaw. James is Professor of Mathematical Biology and Epidemiology at the University of Melbourne, working at the interface between mathematics, epidemiology and public health. This afternoon, James will lead us through the opportunities and challenge of using mathematical models to develop policies to manage infectious diseases. Thank you, James.
Thanks for the opportunity to present today. It's a great honour. So I have over the past 6 months also been an expert member on the AAHPPC, and have worked very closely with Alan and others to help Australia manage this process as well as it could. So what I thought I'd do today is just give a little bit of a background about how a mathematician, a physicist by training actually, has come into this space, and where the sorts of skills that me and my colleagues have can contribute as one small part really to pandemic preparedness and response. So models which have been discussed and debated a lot over the past 6 or 7 months, or 10 months now, have got a role, and there's two distinct roles that they have. The first one is in thinking through future possible scenarios, and this was particularly important in late January, early February, when we had a handful of cases in Australia, just a few people off planes, and there were, you know, a few hundred cases documented around the world. And by looking at the early data in China, there was a fairly quick analysis sort of demonstrated that the reproduction number of SARS-CoV-2 was somewhere between 2 and 4. And what that allowed us to do, and this happened all around the world in many other countries as well, was say, well, if you have a virus that can spread with a reproduction number of 2, so you get a doubling of cases about once a week, if you let that virus spread just naturally through a population, we could project what an epidemic curve would look like based on some very rough and ready early data on how severe it may have been. You could make a projection. It's not a prediction, it's not a forecast, but you could map out a scenario about the potential devastation that this virus could bring. And the modelling, the mathematics lets you do that for an Australian context when there wasn't yet a virus spreading. It's like a thought experiment, and it's no replacement, obviously, for empirical data. What that let us do in Australia was essentially sound the alarm. I remember distinctly the first meeting I had at the AAHPPC where we started working through these sorts of thought experiments, and I believe it was quite important in helping convey the two things. One, the magnitude of the risk that we potentially faced. There was a lot of uncertainty still. The other thing, and I remember this distinctly as part of the conversation, was we could, in those models, say, if we could change transmission by a small amount through either contact tracing or quarantine and isolation, we were able to suggest how much you could flatten the curve. We didn't have that language at the time, but you could flatten the curve. And it was important to convey this, that even a small change in how we might, small change to the virus's transmission could have a dramatic benefit for the population. So that was one of the key things that we did early on. The second role of modelling, which has been a big focus once the virus established in Australia, is what I refer to as situational awareness. It's data analysis. It's sort of a model-based view of classic epidemiology. So where we're studying the data, we're looking at the reproduction number through time, we're asking, with all of the uncertainty around the data, is the epidemic increasing or decreasing? Are interventions effective? Do we need to step up to stage 3 restrictions in Victoria? Is New South Wales at risk of an outbreak at the moment? And that's the type of work that I've been doing day in, day out over the last 6 months. So just before I wrap up, I think I've probably talked one bit too long, but I think some of the really interesting opportunities, we've seen the use and the misuse of models all around the world. And we've also, I think there's a better appreciation across science and the media and the community about how mathematical thinking can contribute to complex decision-making processes. And I think there's a lot that we can learn on that front. So I'll leave it there. Thank you.
Thank you so much, James. That was tremendous as well. And I love the idea that you brought in this concept of how we deal with uncertainty, and that's a really important issue that maths in particular also can help us. But there's a range of other skills that we need in dealing with this. And the next person I want to introduce is Professor Helen Christensen. So she's one of the people physically based here in Sydney. Helen is actually one of the fellows of the Academy, and she's Director and Chief Scientist at the Black Dog Institute and a Professor of Mental Health at UNSW. She's a leading expert on using technology to deliver evidence-based interventions for the prevention and treatment of depression, anxiety, suicide and self-harm. And she will talk about tackling ongoing mental health challenges associated with the pandemic. Thank you, Helen. Thank you. We're just going to do a bit of cleaning before you...
Thank you, and thank you very much for inviting me to come and talk about this topic. So we know already that mental health was knee-deep in problems before COVID hit, in terms of the number of people who are able to get effective treatment and optimised care. COVID really ramped up the problem in terms of there were much more people. Our survey showed that 3/4 of young people were highly distressed, that 1 in 2 adults were feeling psychological distress. As the time went through, January, February, March, etc., we ended up with people who had serious mental illness who were not able to or felt too afraid to go in and seek help for their mental health problems. And we had many marginalised groups who really were having trouble to access the means by which they could get help. Interestingly, our drinking rates went up around 50%, so that 50% of the eligible population were drinking at hazardous levels. But there was no increase, as far as we could see, in the actual number of suicides that were occurring across Victoria and Queensland, where the data were available. As we went further through July and September, the evidence told us that psychological distress follows the movement of lockdown waves, that inequalities emerge and strengthen. We had extreme mental health distress in healthcare workers, aged care workers were under fire, young people had the effect on their careers, and a number of these things Kerry has already talked about today. People were traumatised. I'm being told to move closer. People were traumatised by their loss of family members. Long COVID suggests there are cognitive effects on the horizon. But again, the data that we're seeing internationally and across Australia is that the actual rates of suicide have not increased. So what can we do? What can we make the most of this situation? What positives can we take away? I think we have an envelope of change to improve aspects of how we prepare for the future, and we need to respond wisely. From the mental health positives, I'd say there's 4. The first is that we started to use telehealth. People used online. The problem was that online was still just replicating what we do face-to-face. It wasn't amplifying what digital technologies can actually do to increase the number of people who can be seen. So we estimate with blended care, you can see 9 people compared to 1 person using digital technologies. And there are many, many interesting new models coming out about how we can give better and faster care using these technologies. I think the second thing we learned is that the government has a huge role in moderating the mental health of our communities, and that's through employment. This is a real example of social determinants of health. We're able, I think, to offset a lot of the suicide risk by having JobKeeper, JobSeeker, offering hope and jobs to young people, and we hope to see that coming through. You know, psychological therapy isn't necessarily better than a job. So in these sort of circumstances at mass public health level, we have to recognise the role of major things like unemployment in determining the mental health of our nation. I think the third thing we need to do is reset our view about prevention. We have so few mental health professionals and so much of the population in distress. What are we going to do about that? And obviously shifting it to prevention into the future has to be the way we go, because we can prevent anxiety and depression. The problem is at the moment, the way it's spoken about is very trivially. It's like we're keeping an eye on this rather than setting up those programs that we need to put in place right now to make it much better outcomes for everyone and prevent people from getting ill. For example, screen all young people in schools. Proactively offer brief interventions for people. After the terrorist attacks in Paris, there were walk-in psychological and medical services offered in the streets. We need to reach out to old people proactively. We can't wait for them to come to us. We need to instigate and promote exercise. I mean, one of the things is we're giving out information about what you should be doing about COVID. What about if we promote exercise in the same way at that level? Then we're going to get a change in the mental health of our communities, because we know that that's connected to levels of depression. And so the fourth thing I would say that we need to learn is that we need a preparedness program for mental health. I did a bit of research before, just when COVID came out, looking for what is the preparedness program for mental health as opposed to the preparedness program for medical health. Where's the scenarios? Who's ever thought about this? And it was actually amazing. Nobody had mental health in their preparedness programs. Well, I say, we've learned so much. Let's get a really good mental health pandemic preparedness plan and make it work just as well as a medical pandemic approach. So thank you very much.
Thank you so much. I might ask the next 2 speakers, if they wish, if they're not using slides, to actually just stay and use their microphones where they are as they speak, if that's okay with them. We're covering a whole range of issues related to what COVID has actually raised here. And I want to now move to another speaker, Julie Liske. Julie is Professor and Social Scientist in the Susan Wakefield School of Nursing and Midwifery in the Faculty of Medicine and Health at the University of Sydney. Her research focuses on risk communication, responding to vaccine hesitancy and refusal, and strengthening vaccination programs and policies. Today, Julie will discuss risk communication, those very issues for improving our responses in the context of a global pandemic. Thank you, Julie.
Thanks very much, Louise.
I think you can keep it relatively low.
Thank you, Louise. How's that sound? Good.
So I want to go back to toilet paper gate, March, when this was a time when we know that governments were preparing behind closed doors, when there was preparation about various scenarios, including modelling about that. But what the information that the public were getting was about how many cases we have today, how many cases are in other countries, deaths, and what's happening now, but not what could happen again in the future and how the public could prepare. And because there was a particular kind of information vacuum, people are smart. They know they need to prepare when there's an emergency on the way. And they began to prepare in what turned out to be a reasonably dysfunctional way because of the impact of that at scale. And this event highlights one of the most important lessons from many, many decades of investigation and learning from risk communication, which is that when there's an information vacuum and people feel uncertain, they will make reasonable attempts to prepare, which can result in early overreactions. And what experts tend to do is, in the face of that, tell people not to panic and misdiagnose that attempt to prepare as panic rather than tolerating early overreactions, letting people know what they can do to prepare for a health emergency. So information vacuums are important, and they're going to be important for the future, and I'll tell you why in a moment. In health emergencies, you've got this tension because the people who are assessing risk are very committed to high quality information and careful assessment of the knowledge that they have available at the time. But in the early part of a health emergency, like the beginning of the pandemic, we were dealing with vast amounts of uncertainty about the nature of the virus, things like the reproductive number, the infection fatality rate, so on and so forth. And what experts often want to do is get the information right before they communicate with the public. And so risk communication tells us how to communicate uncertainty, to tell people what we do know now, what we don't know, what we're uncertain about, how we're going to learn more about what we don't know, and what they need to do now. The other point that I want to make here is that, and this connects to a question this morning about misinformation, is that when you have an information vacuum where people are being told certain things but not other things that they want to know, you can often get misinformation filling that gap. So right now we have an opportunity to prepare the public for a vaccine program. Now we have a lot of uncertainty about what that program will look like, but there is knowledge, often behind closed doors, about what sort of scenarios the government is planning for. So bringing the public into their confidence in sharing what they're planning for now and how that program would be delivered, what sort of planning they have around monitoring for adverse events following immunisation. That's difficult communication to have now because there is uncertainty, but it's important to do that now, fill that gap before misinformation does. If there is misinformation that comes, we know it's sticky, and some of the science around this is that it's important to inoculate people against the misinformation and then debunk well and carefully. One very quick final point is that it's not just about the information that people process that will make them change behaviour. And as behavioural scientists, we know that people need to certainly have motivation, but they also need to have the capability and opportunity to engage in those behaviours. And behavioural science has a lot to tell us, and we say we value it, and yet the funding for it is very limited, where we have a budget that's just been announced with $95.2 million from the MRFF and only $600,000 towards communication and behavioural science. And I think that we need to value that science and put some money into understanding it better, because for the time being, behaviour is the most important thing we have to control COVID, and in the future to take vaccines, which is still a behaviour. Thank you.
Thank you so much, Julie. So much to reflect upon there. Yes, there's lots of positive messages here in this with the audience here in Sydney. We now move to our last speaker in the panel, Dr. Norman Swan. Norman hosts the Health Report on the ABC's Radio National, which is the world's longest running health program in the English-speaking world. And since the beginning of the COVID-19 pandemic in Australia, he has hosted Coronacast, a daily podcast answering listeners' questions and covering COVID research. He's really well qualified to talk with us about communicating science and research in the evolving context of a pandemic. Thank you, Norman.
Thanks, Louise. Sorry, a comment about this panel. So this panel, it's not quite as multidisciplinary you get, but it's pretty good. You know, you've got a physicist, mathematician, you've got Alan, who's an ID physician and an epidemiologist, you've got Julie, who's a social scientist, you've got Helen, who's a psychologist, and all really good at what they do and in their fields. And we're living at a time, so I'm actually quite depressed because I don't think we've learned any lessons. And I don't think that we will learn any lessons, because this multidisciplinary approach is in fact what saves us in this circumstance. One example is that you need, in the Northwest Corridor of Melbourne, you needed community development. You needed to be able to talk to communities that were non-English speaking, who had different cultures, and those cultures were spreading rapidly. And we're living at a time of not quite an unprecedented assault on our universities, but an ideological assault on our universities, which seems to extract social science from STEM and disadvantage that. And we are going to pay the price for that moving forward. So that's one thing we haven't learned the lesson of. I hope we've learned the lesson about data. I can't endorse Alan's comment about data more strongly, is that we have to move from data custodians to data stewards. People who have responsibility for data, their responsibility is to share that data, to spread it as widely as possible for maximum utilization. And I'm not sure we've got there with this. And also a uniform basis for how we operate in Australia. And for example, observing the data on COVID-19, on SARS-CoV-2, there's inconsistencies between states. It's getting a bit better now, but it was very hard to compare Victoria to any other state. The changing definitions, lots of backlog. You could see there was a real problem in contact tracing, but it was also a definitional problem. What's my evidence for that we don't learn from anything? In 2009, during H1N1, Victoria stopped testing. Its public health system could not cope with the testing required to control the pandemic. They had to invent a new category of definition for Victorians. That was when Dan Andrews was health minister. Other states tended to improve their resourcing in public health as a result of H1N1. We did not. Certainly Victoria did not. And the result of trim in a centralized system has resulted in the weakness in the system that we've seen exposed by this process. A few years ago, 11 babies died in Djerriwarrh, in Bacchus Marsh, of stillbirths and fetal deaths, which were considered preventable. Major crisis in Victoria, safety and quality, the investigations, and Safer Care Victoria was created. And Safer Care Victoria has been, I believe, muzzled during this process. So how could they have been doing their job with, is it 3,000, Alan will know the data better than me, 3,600 healthcare workers infected of a broad spectrum of professions? Rumours that patients were infected in hospital, and Safer Care Victoria has still not investigated those allegations. And the rumours are that Safer Care Victoria is being controlled by the hospital system, which is much more complex in Victoria than it needs to be, and it's not fit for purpose in a situation like this. Do you think that a year from now we're going to see major reform in the Victorian health system? Of course we're not, because Victorian politicians of all colours have been proud of their system, thinking it's better than any others. It's what stuffed up health reform in 2007 or 8, and it helped to stuff up a national disability insurance scheme because they thought their community service was better than anybody else's. I know I'm having a go at Victoria here, but the problem is the second largest or equal largest state does influence how we do things at a national level. So we need to have national consistency. And the other thing that we need moving forward is transparency, is that we still don't know when various expert bodies advise the federal government on its actions, on what basis they decided that. We don't see the minutes. We don't understand what, there is no exposure to that. And that has created problems, notoriously, about aerosol spread versus droplet spread. Don't want to rehash that now, but you've got the irony in Victoria where you've got a policy for schools which is based on the theory of, that aerosol spread could be a real phenomenon, but not necessarily yet in hospitals. You've got problems in ventilation systems where you've got isolated rooms gassing into general areas. You've got ICUs where they're very uncomfortable with the way ventilation occurs. Engineers really uncomfortable with what happens. Are we going to learn from that? By the way, I know I'm having a go at Victoria. Every other state is vulnerable. It's just Victoria is where it's been exposed. Coming to your question about aged care early, it could happen in any state in Australia if we had enough community transmission. And nobody can actually sit on their laurels. Why is Queensland so worried about its borders? They've lost all social distancing. James McCaw's work on modelling has shown their R effective is what, 1.3, 1.4, James? Something like that. Means that if the virus lands significantly in Queensland, it'll go off. So we don't learn from this. Interestingly, the model perhaps is the ACT. We're surrounded with porous borders, surrounded by New South Wales, not very far away from southwest Sydney, no case now for over 100 days. Canberrans, I think, have changed their behaviour. So they've learned about it. So I think the useful discussion to have is, what are the lessons? And I think each one of the speakers has identified key lessons moving forward that we all need to take into account, because it's not just Victoria, it's all of us.
Thank you, Norman. Well, that's really raised additional issues for us to reflect upon. We now have about just under 25 minutes to have some discussion. I encourage people online to put questions on the Slido or upvote those that are here, and also encourage the speakers, if they want to comment across with each other, or if they've to please do so. Can I start with a question from actually from Don Nutbeam, which is about how can we best communicate with the public the uncertainties associated with COVID whilst maintaining public trust and confidence? This actually goes to some of the issues that several of you are actually talking about. Who would like to address that question first? Julie, yes. So just put your mic on your lap and speak and have it turned on.
So actually, I just gave a talk for the Marie Bashir Institute on this very topic. It's not an easy one, because experimental evidence shows that if you communicate uncertainty during a pandemic about the nature of the disease, people are less likely to intend to vaccinate. Equally, if you are overconfident, or you don't communicate enough, or you don't communicate at all, people will also do the things that I described before. The most important resource in a pandemic is trust, because trust gives you that large-scale community cooperation that you will really need. And so whatever prioritises trust, so you've got a choice between two bad options. Communicate uncertainty, say what we do know, what we don't know, what we're doing to find out what you should do now, will be a more effective way of sustaining trust for the long haul than brushing over things, covering them up, or being overconfident.
Thank you, Julie. Helen, this is clearly an issue that Victoria must be front of mind for Victoria at the moment as well. I was wondering if you could reflect on that particular issue and your understanding about some of these, particularly from some of your broader work.
Yeah, look, I think it's a really difficult issue, and you know, I'm not a professional communicator like Norman, or you know, a professional person that researches how to communicate like Julie. And I guess I'd just try and call it, as I said, I mean, in clinical medicine, we're no strangers in dealing with uncertainty. You know, we say what we do and don't know, what are the options, and then what we might recommend or negotiate with the patient as to what the best thing is. And I think I sort of see it in a similar light. I think maybe a question back to Julie is, you know, one issue that we have, you know, Victoria is extraordinarily, and Australia, in fact, is extraordinarily multicultural, and there's not trust has to be built up over time in a lot of places, and there are certainly a lot of communities where there is mistrust of government because of history and, you know, independent of what the Australian governments might have been doing to them, you know, in their countries of origin, have a mistrust. One of the issues that we've been dealing with is, you know, how do you build that trust very quickly? And, you know, I think we've certainly learned some things in the second wave in Victoria, but, you know, often these communities they're not homogeneous. It's not like you have one particular ethnic group. There are, you know, my group, the Chinese, you know, there are people that arrived a long time ago. There's people like me who are born in Australia. There's, you know, people that speak different dialects. You know, what are the best ways that we can do to, one, communicate with them very quickly, and two, build that trust with them quickly?
Do you have some reflections on that, Julie?
Just briefly, yes, I do, Alan. So it's better if you prepare for the emergency.
Sure.
Before it, you know, so you prepare your communication as well. You have those channels already in place so that by the time the emergency comes along, you can use those channels. Now, we've got them in many ways. Like, for example, in New South Wales, we have public health units, which are in some ways community-based, even though they're very large communities. So you have things like entities like multicultural health units in public health units who already have channels, and even people who live within those communities able to ideally communicate not just what's coming from government, but back up to government what the community's perspectives are. So when you don't have that already established, you really need to quickly mobilise those mechanisms to engage with community leaders and have two-way communication. But it's much better if you do it, if you prepare beforehand.
I think the lesson that we learned was that, you know, there's a multicultural commission in Victoria. There's, you know, there are community organisations. There had been some of that before, and arguably, you know, it might have been done better historically. But some of the populations that we needed to talk to didn't feel that, you know, the peak bodies, multicultural bodies, were representing them, and it becomes almost a generational divide. And a lot of these people, you know, there's the intersectionality of disadvantage. So, you know, they may not really speak their parents' language. They, you know, unemployed youth that have their own issues. They don't, you know, watch television and the usual media that perhaps other people of their community do. And how do you build bridges quickly into a difficult to reach population, as it were, I guess?
Thank you. I might answer, Helen, I know wants to answer, and then I'm going to ask James a question.
Okay, so just a quick one back to Julie. You know, we talk about data. How do you actually measure trust?
Yeah, how do you measure trust?
How can we have a dashboard where trust is going up and down and COVID's doing this, and in the best scenario, how do you measure it?
Well, you can't always measure things. No, I'm very happy with that question. Because we're actually doing work with WHO to measure the vaccine uptake gap, and trust is part of that. So you do things, you measure what you can. You measure confidence in vaccine safety and so forth. You can measure trust in healthcare providers. But I think what's important here as well is mixed methods. So having qualitative data, because that allows you to embrace the complexity of people and their contexts. And that's when you really learn a lot about trust, such as, you know, for example, the Byron Bay community, where there's a lot of vaccine refusal. We're doing a lot of research with parents in that community and learning where their mistrust comes from. I think one of the solutions for preventing mistrust in public health is to have mechanisms to deal with people's grievances well, such as in primary care, such as feedback mechanisms, or through community networks and community leaders, and also with vaccination, to have good processes for dealing with adverse events following immunisation. People don't feel like their concerns are being fobbed off, because then they can develop an enduring mistrust of the healthcare system and refuse vaccination and become anti-vaxxers as well.
Thank you, Julie. I think we're just highlighting the need for a range of skills that are needed here, from really strong quantitative skills, qualitative skills, and being able to, those people with those skills being able to work cooperatively together. I have a question for James here. Could you tell us what you've learned about the problems of modelling through modelling COVID-19, and what would you advise might be done differently in future epidemics?
Right, so thanks for the question. I wanted to make a comment going back one step on uncertainty, but it's actually directly related to the question you've just asked. So there's two different types of uncertainty. There's uncertainty on what the future might hold, but there's also uncertainty on how we should respond, and they can be quite different. Stepping away from health for a moment, climate change is an excellent example. The models and the predictions of how much the Earth might warm are quite uncertain, but the decision that we should do something about it, at least in the science, is highly certain. And it's a similar thing for COVID. Early on, as I said before, when we were first looking at the data and trying to predict what might, or project what might occur, there was a huge amount of uncertainty about what the future might hold for COVID. There was very little uncertainty that we were faced with something very challenging and that we would have to act in a definitive way. So I think, to the first question here, I think I was an advocate for this from the very start, but earlier release of the thinking that we had been doing on COVID, and indeed the pandemic preparedness for influenza over the last 15 years, I think would have greatly helped us, just like Julie said. And so that kind of more regular dialogue, as difficult as it might be, is I think one of the key things that we can take away from this.
So that's going to some of that transparency that Norman was actually commenting upon, to some extent, making that available. And I suppose the challenge, part of the issues there is how that's communicated and communicated well so people understand.
That's right.
I want to pick up on that issue that Norman made before. Questions come in, is that your comments, Norman, remind us how difficult it is to retain the lessons we are learning. Is part of the challenge one of public fatigue and receiving messages they don't really want? If so, how do we overcome that fatigue? Now, who would like to respond to that? Maybe Norman, you'd like to have a go at responding first?
So I think that reform is about leadership and bringing the public with you. I mean, the Victorian system's crying out for major reform, and it's about leadership to move that forward, and that's independent of community fatigue. There'll be blood on the ground. You know, the small country hospitals with their own boards won't want to actually cooperate with other hospitals, so that you get groups of hospitals together covering a population. All sorts of problems, which will require engagement and explanation and a long-term focus. However, it is about leadership moving forward. You do not need to engage the public necessarily in changing the attitude of data custodians so that they share data. You don't necessarily, you do, I mean, there is this problem, which Julie's well aware of, is that when you raise the awareness of a risk, you heighten people's anxiety. So there is this balance between transparency and communicating in advance and actually getting on with change and explaining it as you go. So none of these things are easy, but it's about leadership saying, this is where we have to go. This is how we're going to get there. We're going to have a discussion about it. These are the pros, these are the cons, these are the risks. We are inordinately fearful of privacy breaches in Australia to the detriment of public health. If we were able to geolocate using mobile phones and identify where people are at any one moment, it would have made people like Alan's job much easier in terms of finding out where people are, particularly in a spatial orientation. Yet it was never felt that we could actually move in that direction. So the community fatigue is partly due to repetition of the same message every day. Again, Julie knows more about this than I do, but it's that you get, there's obviously enormous fatigue about lockdown.
So you don't give the same podcast every day. You give a different message every day, but it's around the broader same topic.
Yeah, and that's the problem, say, for Dan Andrews, is and Alan when they do a press conference, is you give the data, you tell what's going on. It sounds the same every day. It kind of washes over you. Is it any different? Well, you're not going to get Alan coming out in a tutu as for a bit of variety here. But you know what I'm saying is it's hard to vary it. But what needs to happen, which is what Alan referred to, is, and Julie as well, is on the ground. Community leadership for targeted communication needs to happen, particularly as we move forward. This is increasingly going to be a disease of disadvantage.
Helen, I was wondering, the issue about disadvantage is Norman's just highlighted, and of course we know that people who are more at risk for mental health problems or who already have mental health problems are part of that group of people who are much more disadvantaged in our community. Would you like to reflect upon how COVID-19 epidemic has some lessons learned in being able to particularly help people with mental health problems? And I know that you've already highlighted some of your particular strategies, but if you want to think, what do you think we could do very quickly or relatively quickly to actually support people with mental health problems?
I think I've sort of pointed out what I think, which is we have to amplify the services we can provide through technology. I know that it's not an easy.
So can I just actually ask you a little bit more about that? What exactly would you do? I mean, I've been involved in telehealth myself in my ordinary clinic.
So,
how would I do that different? How would we do that differently?
Yeah, in the area of mental health, there are digital technologies, apps, online programs, platforms that have been shown in randomised controlled trials to improve mental health or to avert depression. So we already have technologies there already that are offered out, but they're not actually brought into in primary healthcare networks or medical. And so what happens is we still do face-to-face. It might be via Zoom, or it might be spending as much of the clinician time rather than saying, okay, we're going to do it a different way. I'll see you once, then you'll see somebody else who put you through a digital program, you'll do your homework, you'll come back, and the cost and the actual time the clinician needs has been reduced by so much.
So it's a very different model of care. That's what you were talking about before as well. We need a somewhat different model of care, but we've actually got some of the evidence already about what might work.
We've had this evidence for 20 years. This is the thing. I mean, what COVID did was actually make people trust technology because they had to in order to get the health services. So it was a bit of a window of opportunity that we haven't actually embraced. We haven't gone that next step. So I think we're still doing it the same way. We're just using the phone or the Zoom rather than the ways that we can do it. We have to get very serious about how we can amplify the clinician workforce. There's only 4,000 psychiatrists in Australia, and we have 25 million people. And the people who need psychiatry are not getting psychiatry. And so we have to actually rationalise the system and make it more efficient. I mean, these are huge reforms that are required, but they don't seem to ever be taken as seriously as they need to be. If we were having lots of people having these problems and couldn't get cancer treatment or couldn't get help for the COVID diagnosis, assessment and treatment, people would be up in arms. But here we are, we have this system where these people are not getting the help and haven't been getting the help, and it's been exacerbated by the situation.
And we need to move away from fee-for-service to integrated care for people who really need integrated care, chronic disease management, including mental health problems. And we've delayed yet again registration of patients with general practice, which is the first step in providing integrated care where you know you've got a patient population you can look after. So we've put that off yet again. And everybody who's spoken, including before with Kerry and Brendan, recognise that general practice is the core of moving
Absolutely.
forward, but
Yeah.
they're stuck in this model of payment, which doesn't allow them the freedom and doesn't get exactly what Helen's saying is you do not get the appropriate person treating and everybody in the system operating to the maximum of their scope of practice. And so you've got mental health nurses not practicing, psychologists not practicing, and probably psychiatrists under practicing and seeing the worried well sometimes in private practice rather than seeing who counts.
Tick to all that you are saying. We have a question here about how can we improve research access to de-identified health data from across the Australian public health system for research more broadly, as is done at least in some other countries. Who would like to answer that question? It's something that is very dear to the heart of us in the Academy because we're researchers.
I'm not sure I can.
Yes,
I'm not sure
please
I can
go ahead,
answer
James.
it, but I can. I can't answer the question, but I can definitely talk to some of the reasons why it's so important. So, I mean, we've really faced some challenges with COVID, where, for example, if a case crosses the border, or sorry, someone with the infection crosses the border, so they acquired it in one state, but their tracing and the exposure risk to others is occurring in another state, then we have real issues with being able to pull that apart to understand the data and therefore make a better assessment about the risks and the response strategies at a local level. So I think it's about interoperability of systems, and there'll be as many legal and sort of health department cultural issues as there are technical issues. In fact, I think really very little here is of a technical nature. It's more about practice and decisions. I mean, I almost not worried to mention it, but I do think an Australian CDC type approach could be part of the solution there to help, but it's probably
that
not.
Was raised a bit earlier today. Yeah,
it's probably not the silver bullet that people might think it is. So I can see how important this is, and I mean there are some behind the scenes discussions I think about how to make systems talk to each other more effectively. And at the moment, it just adds a little bit of extra layer of uncertainty onto all of the analyses that might be done.
I think, James, yes, please go ahead, Alan.
Yeah, I mean, I think that there are obviously a lot of solutions, and one solution is some sort of data observatory where data can be brought together and there is stewardship of that data. I mean, there are real issues. I remember there was I think it wasn't that, several years ago, there was a 10% release of the MBS database, and people managed to find famous people through that. And, with the Singapore hack, I think you could work out who the Singapore Prime Minister was and, what medication he was on or something. I mean, there are real issues that need to be solved, but, it is possible to set up trusted providers, and there are already, arrangements between, where government would like a piece of work done. There are governance arrangements to go through, and then that data is handed over and analysed in the way, for the purpose that it was done. So I think everything is possible, but there are issues that just need to be addressed, and they're probably most easily addressed, all in one go, rather than with each time someone tries to request a piece of data.
I mean, it's not as if nothing's happening. I mean, the Louise group at the University of New South Wales, Big Data and Health, already has got a very secure level, sort of defence level security layer, which allows access to the sort of, the person that Alan's talking about, which is a trusted individual who understands how to access data. So we already have that, and there's a lot happening under the surface with data linkage and data sharing, but it's not enough. And but the security layer exists. The technology is there.
I'd just like to come in and say it's not actually just about the researchers. I mean, there's people on the ground who need these data sets as well and need them interpreted for them. And so you have this situation where they're all locked up, even locked up from researchers, locked up from the people who need them right now. So I think that there has to be a bit of a mind shift in what can be provided back to health providers, consumers and to researchers.
Might ask Julie to comment now too. Thank you.
So if you have good data and you've analysed it in-house, for example, it's important then to share it with the public. So, for example, with, I think to me there seems to be a gap in what risk factors are highest for COVID transmission, and that could address some of the concerns about aerosol transmission, about COVID being on surfaces for days and days afterwards. How do people get COVID? And, you know, epidemiological evidence is being gathered and analysed in health departments in-house, but I think more of it, some of it's been shared, but I think more of it could be shared with the public so that the public get that feedback and see what's risky for me in my everyday life.
Thank you. Folks, we could go on for another half hour or more talking about these really important issues, but we have come to the end of our time. I've learnt so much today and so much just in this last hour. We've talked about the importance of both amazing qualitative as well as really strong quantitative skills coming together, working together, the importance of diverse skills approaching this issue of COVID-19, the importance of engaging and understanding the community in many different sectors and working across far more than the health sector, of course. We've talked several times about the issue of uncertainty and the importance of promoting transparency. Leadership and bringing the public along with you has been an important issue. Several people have talked about the importance of data stewardship and of communicating and making data available so that people understand that better. I could go on, but we have learned so much here, and I think it really adds to that earlier conversation that we had between Brendan Murphy and Kerry Chant. I want you to join with me in thanking our really fantastic speakers, Alan Cheng, Helen Christensen, Julie Liske, James McCaw and Norman Swan. Thank you all.